Good morning, Frank, for that introduction. I'm delighted to join you this morning. So I'm going to give you a short primer on the question of, is there a role for personalized nociceptive monitoring in an enhanced recovery program? As Frank mentioned, we have been doing a study here at Stony Brook on the monitor and trying to really look at the clinical utility of this monitor. And I'm currently professor and chair at Stony Brook and founding president of American Society for Enhanced Recovery. So the number of surgery in the world has been projected, since 2010 to be about 320 million surgeries needed. And that comes to about 4,600 procedures per 100 populations. And many studies have shown that surgery is a cost-effective treatment of diseases. And so hence you will see that the number of surgery will go up as people are aging and also more technology reach to different parts of the world. Although over the years, the mortality from surgery has come down dramatically and there's some significant improvement, it's estimated that now globally the mortality is about 0.5%. But because of the sheer size of number of surgery, that still means that over 1.6 million deaths per year from people having surgery. And what is interesting is that 80% of the mortality are in the high-risk populations. So what do you mean by high-risk populations? So those undergoing major surgery, elderly populations, patients with coexisting diseases, and those undergoing emergency surgery. Now, although mortality is relatively low, but morbidity is still a significant complications. So if you look at these four morbidity surveys, in fact, it was noted in the US, the mortality in general is about 1.2 to about just under 5% if you look at this quick data. But the percentage of morbidity range anywhere from just under 20% to over 25%. And you'll find that morbidity rate is about 5 to 10 times the number of surgery. So what does morbidity mean? Well, morbidity means that a patient is going to stay in a hospital longer. They are going to develop complications, and therefore there is significant patient suffering. So this is an area that we really need to focus on, trying to reduce post-operative morbidity. So one of the ways to try to reduce that is the implementation of enhanced recovery after surgery. And many of you know that the ERAS protocol has been increasingly practiced over the last 10, 15 years or so. And the principles of enhanced recovery is to see how can we manage the patients using evidence-based methodology to reduce post-operative complications, to improve patient satisfaction, and overall to reduce costs to the healthcare delivery. In other words, we want to get value for surgery, because value is taken into account of not only cost, but quality. We have to have the highest quality at the lowest cost. So these are some of the enhanced recovery elements that have been shown to be effectively reduce the length of stay, reduce complication rate. And you will see that intraoperatively, neuro monitoring is one of those elements that is important for the success of an enhanced recovery program. Now, on the other hand, especially in the United States, we also face a significant problem of opioid addiction. This graph shows that over the years, the opioid addiction, death from opioids goes up tremendously and has been on the rise. Although more recent years, because of societal awareness and because of certain implementation that we have undertaken, the number of deaths from commonly prescribed opioids such as heroin has more or less stabilized, but other synthetic opioids such as fentanyl has still continued to increase. So this is where I think we need to focus our effort to trying to address these issues. Now, while that is certainly one major concern, what I think is sometimes less appreciated is the adverse effects on opioids, because opioids can result in significant adverse effects, a lot of side effects, and that then translate into a longer hospital stay, into post-operative complications. So this study that we conducted a number of years ago using a database to look at what is the incidence of opioid adverse events, and also what is the impact of opioid adverse events on post-op recovery as well as costs. As you can see here on the right-hand side of the graph shows that if a patient has an adverse event as a result of opioids, that patient's length of stay goes up by more than 70% compared to those without an adverse event. And as a result of that, the cost of that hospital stay also goes up substantially. So the greatest effort is trying to reduce the opioid adverse event, because that you reduce length of stay, you reduce cost of healthcare delivery. Now, another area which is perhaps less well focused is this post-operative delirium. Is increasingly being recognized because post-operative delirium, it is common, it is costly, and is deadly. And we know that opioids play a significant role in post-operative delirium. It's estimated about 40% of all surgical patients may be affected by post-operative delirium. And that risk goes up to almost 90% for those patients who are at risk, elderly patients receiving opioids. And it is costly. It's estimated that it costs the hospital US healthcare system about $150 billion. And that equates to about just over $8,000 per patient. And these patients, if they have post-op delirium, increases the hospital length of stay, and it also have twice the risk of readmission to the hospital. And importantly, these events could be deadly. It is estimated that those patients with post-operative delirium, there are about 2 to 4 times increased odds of dying during the hospital stay. And even beyond the hospital stay, it is estimated that post-op delirium increased the odds of dying within 6 months by up to 5-fold. So what are we trying to achieve in perioperative analgesia or pain management? So I think if you think about a framework, on the one hand, surgery is associated with pain. So we have to say, how can we more effectively manage it? So the principle is that you want to optimize patient comfort. In other words, you want to get the pain under control so that the patient can go about with their recovery after surgery, trying to reduce their emotions and also trying to improve their function, improve their sleep. On the other hand, you want to have to achieve a fastest functional recovery, getting them to eat and drink as early as possible, as well as getting them mobilized as early as possible. So these are all elements of enhanced recovery. We are trying to get to the milestone of recovery. And on the third principle is trying to reduce side effects, to have a fewer side effects, because we know that analgesics, opioids, other non-opioids are associated side effects. So by minimizing opioid, you can reduce some of the opiate-related side effects. So I'd like to use this acronym of encouraging post-operative dreams. So what does post-operative dreams stand for? Well, if you're able to drink, you are able to eat, have adequate analgesia, you're able to mobilize and sleep well. So these are elements that I think is crucial for the recovery of these patients getting their post-operative dreams. So in the past, anesthesia has always been defined as these triads of hypnosis, analgesia, and muscle relaxation. And while this concept may be important in terms of teaching about anesthesia, what is the purpose of anesthesia, I think in the modern day anesthesia, what is more important is to try to what we call reducing the surgical stress response. And in fact, those triads of anesthesia are all aimed to reducing surgical stress response. And one of the purpose for implementing an enhanced recovery protocol is really trying to reduce surgical stress response, because we know that with surgical stress response, that result in inflammatory mediators and therefore potentially can cause more pain and patients stay in the hospital longer. So how do we monitor intraoperative stress response? Now, there have been a number of methods that we can do that. I list out some of the ways that you can monitor intraoperative stress, and some of them more practical than others. For example, pupillometry, vasoconstriction by measuring temperature. And one of the most common used one is cardiac sympathetic and parasympathetic tone, using heart rate variability, as well as skin sympathetic tone, using skin conductance. So a number of the monitors that's trying to integrate some of these various parameters into the measurement of nociception, into the measurement of intraoperative stress response. So as I mentioned earlier, that we are doing a trial at my institution, and this will give you some examples of the monitoring norm, where we're trying to keep the number below 25. And again, you can see these 4 examples of different patients. At the x-axis represent the time, and the y-axis represents the no value. And again, if you look at the top left-hand graph, the patients were going along pretty well, predominantly over 20, below 25. And as you can see that when the no numbers go up significantly associated with surgical incision, that numbers went up to about 65 to 75 or 80. And we gave a dose of 50 microgram of fentanyl, and subsequently within the next few minutes, that no number comes down. And again, on the top right-hand graph, again, you see very similar scenario where when the no value goes up, a dose of fentanyl was given. And again, you see a dose-response relationship of the no value in response to the administration of fentanyl. Interestingly, if you look at the bottom 2 examples, where the no was below 25, and because trying to treat the hypotension and bradycardia, we gave a dose of ephedrine in these 2 examples. And again, you can see the no value increases, suggesting there's increased level of sympathetic response. So by using the monitor, it can help the clinicians how to gauge intraoperative surgical stress and whether we could better manage our patients to reduce intraoperative stress, to reduce intraoperative nociception, and therefore potentially improve post-operative outcomes. So what are the take-home messages? Well, as I mentioned earlier, while mortality is low, but morbidity is still high, 80% of surgical mortality are in a high-risk population, and morbidity is the one that causes significant complication, is associated with increased cost, associated with suffering and length of stay. Enhanced recovery after surgery strategy has been demonstrated in many studies to improve post-operative outcomes, also reducing the cost for healthcare delivery. Opioid causes numerous side effects and prolong length of stay, increasing patient discomfort, nausea, vomiting, delirium, as well as the sedation and respiratory depression. And I believe that individualized nociceptive monitoring may reduce sympathetic response and therefore optimize analgesia, help us to manage the intraoperative administration of opioid and potentially reducing opioid utilization. Thank you very much for your attention.
Thank you, TJ. That was a great presentation. I'd like to ask you some clinical questions relative to your experience. And starting with the first one is an overall clinical need question. How does interpatient variability, specifically when it comes to opioids, impact patient management?
Frank, you know, one of the issues that we deal with in the operating room is about managing variability, right? Now, we often administer drug. Usually we say, okay, this is weight-based, but we don't consider that patient comes in all forms of shapes. They have different pharmacogenetics. They have a different metabolism. So I think the issue that we have is really managing variability. Now, you will see that often if you give, for example, a certain amount of anesthetic, which may be adequate for some, it may not be adequate for others, it may be an overdose for some elderly populations. So managing variability is, I think, the key. And the way that we manage variability is to be able to have more information. So in the context of neuro monitoring, this is where I believe that if you monitor the patients, that is the key to be able to say, okay, where is this patient as far as the needs for opioids? Where is this patient as far as the needs for sedative? And we have seen that with bispectral index. There are doses that we feel that is adequate, but in some patients, it is underdosing. In other patients, it is overdosing. So without monitoring, it is impossible, I believe, to really know where exactly the patient's needs. And as a result of that, we are at a loss in terms of what is the right dose for that particular patient.
So, and that's perfect. I like how you call it neuromonitoring. I never really think of it as neuromonitoring. I always think of depth of anesthesia, BIS as neuromonitoring. But yes, it is. It's sympathetic nervous system monitoring. So it is neuromonitoring. So let me ask you specifically which patient populations this would be most useful in. There's probably a niche. Is it the elderly? Is it opioid tolerant, morbidly obese? Because dosing per kilo is obviously an archaic and really not something very relevant to what we should be doing. Which patients do you think the null monitor will help you most in?
So Frank, I would tell you that what my question to you is this: which patient do you think that pulse oximetry will be helpful? Now, if you were to say that all patients, then I would say all patients, neuromonitoring will be useful for all patients. Because the reason is this: we can't predict who are the ones who were going to be needed for neuromonitoring during the operation. Sometimes if the surgery goes well, there is no problem, just like when you do an ambulatory procedure, pulse ox is always 100%. Sure, but we don't know at some point that patient's saturation may drop. And if you don't have pulse oximeter, you have no idea when the saturation drops. So I think that, in the ideal world, we really need to monitor every single patient, because we just can't predict which are the patients is going to do better or which are the patient going to develop complications. And during surgery, things changes. So my analogy is that, when do we need pulse oximeter?
That's a great one. I hadn't thought about it that way, but you're absolutely right. What you're basically saying is it's not just the patient, it's also the procedure, it's the surgical circumstance at the time. So let me try this question again. Is there any particular surgery or procedure that you think this may be more relevant initially than not?
Sure. I think what you're already trying to get at, Frank, is what is the cost-benefit ratio, right? In every situation, we have to weigh that cost-benefit ratio. In a straightforward ASA1 short procedures, probably that would be a lower on my list of needs for that monitoring. In patients who are elderly populations undergoing major procedures where there is a significant sympathetic stress associated with it, where administration of opioids will be predominant during the surgery, in addition to non-opioid, which we advocate multimodal analgesia. But despite that, we still need to give some opioids. So those patients who have a high comorbidity, so we need to try to reduce the amount of opioids that we administer to these patients, so that post-operatively these patients would not be a result of overdosing of opioids, resulting in opioid complications. So to your question, I would say that, elderly populations, people who are high risk, comorbid existing diseases, people who have got respiratory compromise, major surgery, these are the ones what I call sort of higher yield for population that this monitor in conjunction with other neuron monitoring will be very helpful.
Okay. Yeah, I totally agree with you. It's really very much an issue of circumstance. You mentioned delirium in your talk, and traditionally, the post-op delirium, to me, we've had that very broad distinction, general versus regional. Regional is an advantage for delirium because of our general anesthetics, but you mentioned that opioids play a factor in that as well. Can you tell us a little more about what you think best case may be an advantage of the null in that situation?
Sure. So as I mentioned earlier, opioid is one of the key factors associated with delirium. So if you can reduce, even abolish the use of opioids, certainly that incidence goes down. Now, obviously, there are other factors associated with delirium as well, but some of the factors we can control and others we can't. So for those that we can control, such as the administration of opioid, we have to try to give the optimal dose of opioids. Again, I believe that opioid has a role during surgery, but we have to use some of the non-opioids, and using opioids more of a sort of modulating the effect, and also trying to minimize the amount of opioids. And by able to monitor the stress response, so that can help us to minimize the opioid that we use. And also, more importantly, at what point should a dose of opioid be given? As I showed it in the examples that earlier on, that doesn't mean that when the pressure goes up, that means that you need to give a dose of opioids. Hypertension is not always associated with either inadequate analgesia. So by using a stress response, using a nociceptive monitor, that can much better target at what point is an opioid required.
Great. You mentioned, let's talk about hemodynamic instability for a second. And, some of the studies have shown that it's really that timing of the opioid that's so key in gauging when to give the opioid. What is your sense of the potential for null to improve hemodynamic stability during the case?
Right. So I think during the operations, we know that traditionally we have relied on blood pressure, we have relied on heart rate, we have relied on features of sympathetic response to help us gauge the depth of anesthetic, as we call it. So as a result of that, we often respond to either hypertension or tachycardia. We give a dose of either opioids or potentially with present hypotension, we give a bolus of fluid. Now, while that has been the general teaching in the past, but that doesn't necessarily always be true. For example, as I said earlier, hypertension doesn't always means that the patient is inadequately analgesic, right? And also potentially maybe patient has a primary hypertension before coming to surgery. Likewise, if patient is hypotensive, doesn't necessarily mean that the patients need fluid. It doesn't necessarily mean that the patient is to have adequate analgesia. So I think using a monitor that specifically measures the stress response, specifically measure the nociceptive level of the patient, that would help us better administer the right drug and at the right time.
Excellent, excellent. Now, you are known as an excellent clinician and academician, but you're also a chair, and so you have financial and administrative responsibilities as well. How do you see this technology being rolled out into practice? How would you decide if you, after your studies, decide there's clinical benefit? How would you do that?
Now, that's a good question, as we are always challenged with increasing healthcare costs. And we, as responsible administrator and department chair, and also working with the hospital, trying to minimize costs. Now, while minimize costs is really not the primary objective, I think what is more important is getting the best value. So how can I get the best value, whether it's any drugs or any monitoring device? Now, value doesn't equal to just reducing cost. There is a quality in that equation. So in other words, how can I achieve the best quality for this patient I'm looking after at the least cost? So that comes into important discussion as to what is the value of this monitor offer. If the value of the monitor is such that it can potentially reduce complication, reduce length of stay, reduce long-term side effects, even though it may be associated with a significant cost, it would still be better off because overall it's a cost savings to the hospital, it's a cost savings to the society. So I think more important is that whether there is a demonstrated evidence that a monitor result in reducing post-operative complication, reducing length of stay. And if that is the case, I think that would be a significant, important decision for deciding whether a monitor or a drugs. In fact, if you look at enhanced recovery has been shown to improve post-operative outcome. But there are certain monitoring devices, there are certainly drugs that may be associated with cost. But if you can save the overall cost for that hospital admission, if you can save overall cost for society, that is where we need to consider using this technology, using these drugs to try to improve post-operative outcome.
Excellent. And obviously you're one of the founding fathers of ERAS and early adopters, and you just basically framed that in the context of your earlier slide with all the components of ERAS. And I guess that's where this monitor will fall into the neuromonitoring side, depth of anesthesia, depth of analgesia kind of monitor. Anything you want to share with the audience about your early experience? I know it's early, you haven't done that many cases, but it sounds like you are intrigued by the potential of this technology.
Yes, I think, based on what we have seen, I think the first of all, it's important to have a dose-response relationship so that when you administer opioid, you can see the value of no changes, as I showed you earlier. That is a first step to get any clinicians to have faith in the monitor. In other words, I'm instituting an event and I give a dose of opioid, the number changes. No difference from when in the early days of bispectral index, where you give a dose of a sedative, that base comes down. Just like you induce with propofol, that base comes down. So that is the first step to convince clinicians that this monitor has clinical utility. The next step is really to show that by using the monitor in an algorithmic, in an algorithm that is suggested by the manufacturers to say what is the best to use a monitor. If you follow that, can you, number one, reduce the amount of opioids? Number two, does it reduce post-operative complications, potentially reducing length of stay? Those has to be demonstrated. And I believe that, if you have good evidence to show that this monitor is associated with a reduction in opioid use or a reduction in post-op complication while maintaining analgesia or even enhancing analgesia, that goes a long way in terms of using this monitor on a more clinical basis.
Excellent summary. TJ, thank you very much for sharing your early experiences with this monitor. We really appreciate it. And we look forward to hearing more from you as you go along in the study and you use the PMD. Many, many thanks.
Thank you very much, Frank.